Imbecile.
Moron.
Incompetent.
Useless.
Idiot.
Overbreeder.
The words ringing in minority women's ears for decades in America. From the years of 1910 to 1970, over 60,000 people were forcibly sterilized. Over a quarter of these were performed in California alone. A plethora of hatred and fear in white communities was caused by a heavy foundation in nativism, every sector of education supporting eugenics, and a massive Mexican immigration to California. Rampant stereotypes emerged in California, among which was the idea that Mexican women were overbreeders, leading to many cases of forced and coerced sterilization. Then, finally, in 1978, 10 Mexican women and 2 Mexican lawyers took a stand against years of injustice. The lawsuit Madrigal v. Kiligan fought against the unethical sterilization of Latino women by taking a stand for Latina civil rights. Sterilization's final researchers. Just as the medical world was exploring the applications of eugenic ideals, the judicial world was excusing and encouraging it. In 1927, the Supreme Court case Buck v. Bell gave pro-sterilization advocates an ironclad legal argument to defend themselves. Carrie Buck was sterilized because she was classified as a moral delinquent, feeble-minded, a middle-grade moron, and incompetent. In fact, one of the judges vocally agreed with the decision by famously stating, "3 generations of imbeciles is enough," in reference to Carrie, her mother, and her daughter. It also reinforced the notion that states had the right to sterilize for the benefit of society. However, the justification of eugenics changed dramatically post-World War II. The idea of purifying the American bloodstream was too reminiscent of Hitler's final solution. Therefore, eugenicists evolved to preserve public opinion by transforming their platform. The idea of sterilization became a noble cause for the preservation of the earth and the defense of the rights of unborn children. This shift is best exemplified in The Population Bomb, a book written by Paul R. Ehrlich in 1968. Greatly influencing America's views on society and population control, Ehrlich included doomsday scenarios to shock and awe the reader. His point was that the world was reproducing at an unsustainable rate, primarily the fault of the poor, uneducated, and minority masses. The population bomb caused the explosion of fear-induced racism and frantic sterilizations. This panic carried over into federal legislation as well. Postpartum tubal ligations were financially funded by federal agencies supported by Lyndon B. Johnson. Due to this overwhelming support, hospitals began to meet sterilization quotas, and they would receive grants for the amounts of procedures executed. One of these hospitals was County Hospital, located in Los Angeles. In 1973, a health research group report named County Hospital as one of the worst offenders of sterilization abuse. Surrounded by minority communities and the only public hospital for miles, Latino women would travel for hours by bus, in labor, just for medical care.
What was basically happening was when women were in the throes of labor pains and under tremendous distress, they would be sort of bullied into signing something because otherwise it would slow down the getting into the delivery room and actually deliver.
Unknown to countless women, they had just signed away one of their most precious rights, having children. In May of 1978, 10 low-income Spanish-speaking women sued County Hospital for non-consensual sterilizations. They were represented by 2 young Chicano lawyers, Antonia Hernandez and Charles Navarre. All of the plaintiffs had been coerced into postpartum tubal ligations immediately after C-section births. Doctors purposefully gave the women false information after many hours of labor to coerce them into sterilization. Rebecca Figueroa was told the procedure was reversible. The trial was 2.5 weeks long, and it was riddled with overt bias towards the defendants. In fact, Judge Jesse Curtis was a supporter of eugenics. He ruled against the plaintiffs, saying that the doctors had good intentions and meant no harm. Curtis excused the doctors' motives of stopping an overpopulation problem and indirectly blamed the plaintiffs' Mexican culture for their anger about the sterilizations. Although the plaintiffs lost the case, they won the public's support. Although Madrigal v. Kiligan inspired many changes in American legislatures and society regarding sterilization and Mexican acceptance, America still has an uphill battle in terms of good relationships with the country of Mexico and its people. Despite this, coerced sterilization has stopped almost entirely in the U.S. One can speculate that if not for Madrigal v. Kiligan, the issue of coerced sterilization would have gone on for much longer, especially for Latino women. No other lawsuit had brought to light the systemic problems of forced sterilizations. Contrary to society's thoughts of Latino women being incompetent and useless, they sparked a nationwide change. With the plaintiffs' bravery, they took a stand against injustice so that future generations would live in a fairer world. They fought so that doctors would be held not just to legal standards, but also to ethical ones.
Good morning, everyone. Thank you for joining us. Thank you for watching the preview video. I'm Dora Muhammad, the Congregation Engagement Director at the Virginia Interfaith Center for Public Policy, as well as the Health Equity Program Manager. And today we have joining me 3 wonderful speakers who will delve into our final topic around ethics in healthcare. We'll be talking about the principle of beneficence. And so it was not planned, but as the development of today's panel and lineup came about, we really centered on maternal health. I absolutely knew that I wanted to begin on the topic of sterilization in the US, as the video showed, for a couple of reasons. And 2 clarifications I do want to make. Even though that video that we shared said it was the final chapter of sterilization, it actually has not been. We know that there's been recent cases in prisons, in ICE detention, and in some of the hospitals where sterilization, unbeknown to women, has occurred. So the fight does continue, and it is a barrier for trust. And so hopefully today's talks will unpack that, and so we can sort of see, under the theme, how to create trustworthy healthcare settings. So before I introduce the speakers, I do want to just sort of go into a brief definition of beneficence. So the first 2 talks that we've had, we focused on justice and autonomy. And the principle of beneficence does build on those 2. So I think everyone kind of knows that the sort of the principle of the maxim really for the medical community is first, do no harm. And so we understand beneficence through a lens of faith, by meaning it's doing good unto others. And so we're really wrapping those 2 up. And in some medical communities, it is one rubric as well, where it's not just sort of, in the lens of faith, it's voluntary. It's an act of charity or kindness, doing good to others, very arbitrary. Within healthcare, it becomes a real duty. It becomes an obligation. There's much more accountability around making sure that the clinical decisions for treatment that are made are actually going to benefit the patient, that they are really to help support the welfare of the patient. And so even further than that, in terms of an ethical framework, it is even stronger, where it's not just doing good that will benefit the patient, but also removing harm. Also, even further than that, it's preventing harm, looking at circumstances and conditions that will cause harm and how do you address them so that the harm doesn't occur. So this is the framework for the principle of beneficence in healthcare. And so I want 2 more notes on history. As we focused on the case in California, I kind of sped through some of the video for the sake of time, but we will provide the link for the full video for people to watch. But because of the activism and the advocacy of the Chicano community and larger, just honestly people who understand human rights, the state of California did repeal its law for sterilization that supported it. The state of California also did an official state apology that was issued by the governor. And then just this summer, the state legislature passed and Governor Newsom approved in their budget a $7 million, I think $7.5 million budget line item to provide reparations to the survivors of California's sterilization program that began in 1909. So again, even though it came to light in the 70s, this had been going on for nearly a century. And so with that background, I'm just so very thankful again for the women who have joined me today to really unpack this principle. And so I'm going to spotlight each one as I introduce them. You'll hear first from Stacy Cordova Diaz. She's in California, so I do thank her and bless her for joining. It is 7 o'clock her time. But she is the great niece of Mary Franco, who is one of the women, the Latinas, who were sterilized during the 70s by the state of California. And so, oh, she's probably going to correct me. And so she maybe it wasn't the 70s, did I get the timing wrong? And so she is really, since learning her family's history, her aunt's history, she thought it was a family secret. She's going to delve into how learning, as a woman, her great aunt's history has now propelled her as a justice fighter, not only for her aunt, but for all women, knowing this history is not just California's history, but this country's history. A wonderfully bold activist. You'll absolutely be inspired by what she shares. Also joining us after that, you will hear from Divya Hosangadi. Did I say it right? Okay. Yes, beautiful. And so Divya is a senior policy analyst at the Johns Hopkins Center for Health Security. Powerful name for the division that she works in. One of the things that intrigued me about Divya's work is that she has been on the front lines of addressing misinformation during the COVID pandemic. And so she's going to go into that and sort of is linked to health security and specifically highlighting sort of where that work has intersected and beyond, but where it has intersected with sort of the misinformation about the vaccine's effect on fertility and population control. Very powerful work that she's doing. Thank you for joining us to share the perspective from the advocates' work that you are doing. She's also very involved in several community coalitions. So it's not just her professional job. This is something that she truly believes in and has extended beyond Johns Hopkins. And then third, and definitely not least, but last, pulling up the rear, I'm so very excited. I searched high and low. And again, I tell people I really do feel so divinely guided and inspired in this series. I came across the Trust Practices Network of the American Board of Internal Medicine's Foundation. And I was just floored by the length and the breadth of their intentionality of creating real specific directive practices to create trust within the medical community. And it was important for me to amplify that. And it's really sort of, honestly, the best note to end on this series. And I struggle so hard to find, because the network is so vast, it is nationwide. And I came upon work that Dr. Amber Weiseth, who's joining us today, is leading. It is an initiative that was developed in response to the rise in avoidable C-sections. And I thought, well, how perfect. And so the link of maternal health is throughout today's discussion, which if anyone who's familiar with our work at Virginia Interfaith Center and our health equity priorities, reducing the disparities in maternal health and maternal mortality has been something that we've been focused on for the past 3 years. And so it's wonderful to see my work sort of coalesce in this space, again, as the final talk in this 3-part series. And so Dr. Amber Weiseth, she works for, I'm going to say it wrong, so I'll just say it's a joint center. It is a joint center that's created for Brigham and Women's Health Hospital and the Harvard, I'm going to say it all wrong, Harvard T.H. Chan Public, no, I'm saying it wrong, so I'll have you introduce it, but it's the Harvard School of Public Health.
That's perfect, Dora. And we usually talk at the Christmas party every year about the ways people mispronounce Ariadne Labs. So you are not alone.
Okay, good.
And you did a great job.
Thank you so much. So anyway, so thank you all again for joining me. And I will say, I'd like to highlight again, this entire series, I've been blessed to amplify women leaders in this space. And so with that, I'm going to turn it over to Stacy to begin our talk.
Thank you, Dora, for your lovely introduction. And also thank you for showing that video. I think it's interesting for everyone to know that I was actually born at LA County USC Medical Center. I was born in 1976. I was born during the time that this was happening, these forced sterilizations. However, my mom spoke English. And what's another interesting fact about all those women in Madrigal v. Culligan, not one of them was on welfare. And I think that's an important thing to state, because that was a misconception. So I will start with my story. And this is my aunt's story. So my part of the story begins in 1997. I was an undergraduate at Loyola Marymount University in Los Angeles, California. It was a Chicano studies class that started me on this journey. The assignment was to interview someone who lived the Chicano experience. This was easy for me because I am Mexican American and I have many aunts, uncles, and family friends to choose from. But I decided I wanted to hear my great Aunt Mary's story, not knowing and not realizing that I was going to hear such a heartbreaking account. My Aunt Mary was like a grandma to us. She was always visiting our home and we would visit her. She was an important part of our family, even coming to my open houses while I was in elementary school. My Aunt Mary was full of spirit, equal parts funny and feisty. She would give you the shirt off her back and also a piece of her mind if you did something that disappointed her. When I was young, I loved hearing her funny stories. She was always full of surprises. It was in her small apartment when she began telling me her story of being a young girl in Southern California. Mary de la Paz Franco was a United States citizen. She was born in Arcadia, California, to two strict immigrant parents from Mexico. Mary was the youngest girl of 8 children, and she would often be helping her parents and older siblings take care of their households. My aunt shared that she loved the attention of the boys, but sadly, it was not the attention of the boys in her class that she was getting. It was from an older man that lived down the street from her. This man began paying close attention and treating my aunt to little gifts every time she went to the corner store. The man began calling my aunt his girlfriend and asked her to call him her boyfriend. As my aunt recounted the story, she called him a cochino, which is a slang term in Spanish for a dirty old man. But she said she liked the attention and the gifts he gave her. This man, who was in his late 40s, began molesting my aunt. She was only 13 years old. At school, my aunt told her friends what had happened between her and the older man. The scandal of what was going on with Mary and the man grew quickly. And when the tight-knit family began to find out, they wanted the gossip to stop. Instead of going to the police or confronting the molester, they instead took my aunt away. It was on Wednesday, March 14th, 1934, when my aunt was taken to Pacific Colony State Narcotic Hospital in Spadra, California, which is now known as Pomona. I later learned that Pacific Colony was built for the sole purpose of sterilizing the growing population of California's feeble-minded. She was driven by her older brother, Joe, my grandfather, her sister, Mercedes, and her parents. She was placed as an inmate. It was here that her life was changed forever. At 13 years old, she was forcibly sterilized. The doctors from the facility performing a self-injectomy on her young body. She blamed my grandfather for doing this to her. When I heard this, I was utterly shocked. Anger towards my grandfather and great-grandparents welled up in me. I thought, could all of this really be true? I couldn't wait to get home and ask my mom if all of this really did happen. My mother confirmed that it was true and that we should never speak of it again. It was during the Great Depression, and the family did what they had to do, never really finding out if the family fully knew what was going to happen to her at that hospital. My aunt passed away shortly after that conversation, And sadly, we never spoke of this shameful family secret again until 2017. 20 years after my great Aunt Mary told me her story, I was driving home from work listening to National Public Radio. I heard Dr. Alexandra Minna-Stern discussing the eugenics movement in the United States of America, and that California was the #1 sterilizer. Their primary target, people with Spanish surnames. I pulled over. I could not believe what I was hearing. I wrote everything down that she was saying. I went home, looked up Dr. Stern, and emailed her immediately. She wrote back that evening and put me in contact with the researchers from the Sterilization and Social Justice Lab. They found all of my aunt's documents, her intake paperwork, the form written by hospital staff recommending sterilization, and the signatures of my great-grandparents giving permission for them to perform the surgery that would take away my aunt's ability to give birth to children. The signatures of 2 people who could not read, write, or speak English. Her files showed she had an IQ of 53. She was labeled, and I quote, feeble-minded, low-grade moron due to sex delinquent. She was just 13. I keep going back to her being 13 years old because the researchers all said she was one of the youngest they had seen. The researchers also shared that the officials fast-tracked her procedure, something they typically didn't see in the many files they scoured through. I know my aunt did not have an IQ score of 53. Mary Franco was an independent woman who lived on her own for the majority of her life, working full-time and supporting herself without the help of anyone else. The ironic thing in all of this is that I'm a special education teacher and work with students' IQ scores on a daily basis to determine programs and plans of action to help them succeed in school and in life. My aunt's story and the stories of so many others forcibly sterilized really spoke to me on many levels. As a teacher who works with students with special needs, the orthopedically impaired, visually impaired, learning disabled, deaf and hard of hearing, they would have all fallen under the umbrella of feeble-minded. There was one other similarity between my aunt and I that really hit home. I would have been labeled sexually deviant if I had lived during 1934. I could have been sterilized as well because I had a baby when I was just 15 years old. The shame I felt for bringing shame on my family was the shame my aunt carried for disgracing her family. The shame she carried was completely undeserved due to the tragic circumstances of her molestation. My aunt should have been protected, but instead she was sterilized. I will never forget that day in my aunt's living room and her sharing that she felt no one ever truly loved her because she could not bear them children. My aunt married once when she was 18. She believed they were madly in love, but when he found out she could not have children, he returned her back to her childhood home and never returned. The marriage was annulled and she never married again. At 77 years old, my aunt went to her grave feeling the weight and shame of this. This shameful family secret that I thought only affected my family was now the shameful secret of the United States of America. My Mexican-American family was a part of American history. I am sad to say that the law that makes forcible sterilizations legal still stands in the US Supreme Court today. The infamous case Buck v. Bell from 1927 has never been reversed. My goal through my advocacy work is to one day see this law repealed, and I would love to see Justice Sonia Sotomayor accomplish this. We have had some wins on this journey, as Dora said, of educating people about this history. In July 2021, California's governor recently signed in the state budget to issue reparations for the living victims of forced sterilizations and to ensure that people are educated on this past. I believe my aunt gave me a gift that day. She told me her story. It is my honor to share her truth and legacy with others. We must all be educated on this horrendous part of our country's history so that we do not repeat it. We can only do this when we open our hearts and minds to the truth. Keep learning and keep loving. Thank you.
Thank you so much, Stacy, for speaking and opening your heart with us today. I know it's very emotional for you, but thank you. Because honestly, advocacy has to come from the heart. And for us at the center doing faith-based advocacy, that's really where the connection comes from. And so I'll circle back to a couple of things in my closing thoughts based on what you said. But thank you so very much. And so next, Divya, if you want to come back on screen so that we can have you share. There you go. So next, you all will hear from Divya.
Wow, thank you so much, Stacy, for sharing your aunt's heartbreaking and incredibly important story with us. I got emotional listening to that, so thank you so much. Hello, everyone. As Dora mentioned, my name is Divya Hosangadi, and it is a pleasure and privilege to talk with you all today about COVID-19 vaccines, as well as the harms that misinformation pose about the vaccines. I'm a senior analyst at the Center for Health Security at Johns Hopkins, and we're an academic policy research center that focuses on pandemic preparedness and response. And health security is often viewed in terms of the infrastructures and the systems that we can establish to best protect ourselves now and in the future from public health emergencies. We know that emergencies like pandemics endanger people's lives and well-being. And so I've done research primarily studying health misinformation that can spread during pandemics, as well as the best ways that we can support vaccine confidence efforts and support vaccination uptake in communities of color in particular. So along with my colleagues Tara Kirksell and Mark Trudishad, we've studied how misinformation spreads during pandemics and how that can really affect public health response measures. And as part of the Communivax team, led by Monica Shaxbon and Emily Brunson, we've learned how exposure to misinformation can really intersect with existing distrust in vulnerable communities due to longstanding acts of injustice and medical violence that have occurred within these communities, and how that contributes to lower uptake and confidence in vaccines. Today, there are over 234 million people in the US that have now had at least one dose of a COVID-19 vaccine, but there's still millions of people across the country who remain unvaccinated or not fully vaccinated. Meanwhile, since the start of the pandemic, there have been around 50 million COVID-19 cases and more than 800,000 deaths in the US alone. The pandemic has robbed us of spending time with loved ones and friends, and many people across the country, in addition to experiencing the tragedies of loss of life, have also experienced economic hardships as a result of this pandemic. Getting vaccinated with a COVID-19 vaccine is one of the most effective ways that you can protect yourself from getting the disease so that we can move forward. But there are a few different reasons that people may not want to get vaccinated yet. And one of the main ones is exposure potentially to misinformation, disinformation, as well as politicizing the vaccine. There are several different types of misinformation that often circulate during pandemics and other health emergencies. Some of them include false information about the virus itself or the characteristics of a vaccine or health measure. Some of it includes false cures or false treatments, and also conspiracies about the vaccine or about the treatment, particularly in relation to population control, as an example, or profiteering. So I'm going to focus particularly today on misinformation related to pregnancy and fertility. A common misperception out there about the COVID-19 vaccines used today is that the vaccines cause infertility or that they harm pregnant women. Based on the studies that have been conducted throughout 2021 and the data assessed, there's no evidence to support this. There are even false rumors out there that state that just being a woman and standing near another woman who may have been vaccinated could affect your own fertility. And this often relates to false information that the vaccinated people shed the virus or they shed the vaccine, and this is not true. It's really understandable, especially if you're a pregnant woman or a woman who one day may want to become pregnant. It's really understandable to have questions or to feel uncertain. Pregnant women were not included in the initial clinical trials, and so it took some extra time to really assess and to make sure that these vaccines are safe in women. But several studies conducted throughout 2021 have shown that getting the vaccine does not increase the likelihood of having a miscarriage, nor does it decrease the likelihood of women being able to become pregnant in the future. And there are also ongoing studies to further assess these questions. When a woman gets vaccinated, the vaccine does not travel to the placenta and it does not affect the fetus. But what the vaccine does enable is for the pregnant woman to protect herself from getting COVID, and also to protect the fetus growing in her by protecting herself. And when the baby is born, the protective antibodies that the mom has generated get transferred over via the breast milk to the baby. And so the baby then can have protection against this deadly disease. The rumors circulating about the vaccine have contributed to lower vaccination rates in pregnant women, despite the fact that the CDC recommends that pregnant women get vaccinated. Today, only around 35% of pregnant women in the US are fully vaccinated, and there are substantial differences by race and ethnicity. Only 21% of Black women, for example, have been vaccinated. And the consequences of that can be deadly. Pregnant women who get sick from COVID-19 disease, particularly those in high-risk pregnancies, are 15 times more likely to die in the hospital. It can be really hard for people to recognize misinformation in general, and there's a few different reasons for that. First, our research has shown that misinformation is often mixed in with subtle half-truths or partially true information, and so it can be really hard to kind of parse out what is correct and what isn't. Second, it's much easier to believe misinformation that reinforces your perceptions or your experiences that you have had, or misinformation that aligns with your political or worldview. It can thrive on and worsen distrust. And it can be psychologically harder for people to really identify and critique those statements that align with their experiences. And misinformation and disinformation are designed to make you want to believe it. They often are using shocking or provocative information that instills emotions like anger and disgust and fear to make that information more compelling. And websites that share misinformation and disinformation often use communication styles that are far better at speaking to your emotions than public health researchers and scientists like myself. People like me, we often like to use numbers, we like to state hard evidence, and we tend to avoid language that sensationalizes everything. But websites and other sources that spread misinformation, they often share very emotional, but sometimes dubious anecdotal evidence that isn't really supported by the factual evidence that has been collected. There are also, of course, intense structural barriers that enable misinformation to spread, starting with the long history of medical violence that has occurred in vulnerable communities, but also a lack of accessible, accurate, and culturally relevant resources that can enable communication across different populations. So for example, language barriers can make it harder for you to communicate with your healthcare provider or to access the information that you need. And a lack of culturally competent resources may mean that the information that you find is most relevant to you may not be coming across in the resources that are generated by public health sources. Also, if the messengers that are trying to dispel misinformation aren't from your community and they can't really relate to you or to your experiences, that can make their efforts less effective. So all of these reasons can play a role in why some women, particularly women of color, may experience being hesitant or unsure about getting the vaccine. And as I mentioned earlier, there's this longstanding distrust in the medical community due to the history of medical violence. But also it's because often the concerns that women may have, they can often be dismissed by medical professionals or the medical establishment. And so when women are not taken seriously or they are disrespected by people in authority, they can often seek alternate outlets to get the respect and the attention that they do deserve. And so often that means looking at alternative medicine sites or natural healing and wellness sites that, may not necessarily have the most accurate information, and that can further fuel distrust or spread misinformation. Studies have also shown that a lot of these websites that are spreading the vaccine disinformation, as well as the social media companies that kind of allow these sources to spread, have profited from spreading this information through increased ad revenue or through selling products. And so they have an ulterior motive as well for some of spreading for the information that they do. And so tackling misinformation and disinformation happens at multiple different levels, including work that's done by public health professionals and academic researchers like myself, but also from folks like you who can help stop the cycle of misinformation. In the research community, this means often we need to support hearing from trusted voices in your community, who can listen to your questions and understand where you're coming from. And sometimes that means thinking creatively about who serves as an advocate, working with barbershop owners or stylists or leaders of the faith community to make sure that these messages can come across and that people's voices are being heard. If you're pregnant and unsure about getting the vaccine, I really encourage you to call the CDC info hotline. That's 1-800-CDC-INFO, and to look at the CDC website for more information, but to also talk to a trusted medical provider like your OBGYN to ask the questions that are important to you. And also to listen to the experiences of your friends and family who may have gotten vaccinated and learn what it was like for them. I also want to remind you that the ingredients in the vaccines are publicly available, as is the evidence that was used by an independent panel of experts to make recommendations to the CDC and FDA. And so you can look at this information yourself, and I'm happy to share it later. If you are an advocate and you have been vaccinated, I really encourage you to talk with your neighbors, your family members, your friends, people in your community to encourage vaccination and talk about your experience getting the vaccine, but also approach those folks who may be uncertain with empathy and hear them out. Ask open-ended questions to learn what their concerns or questions are and what their priorities are. Try to see, what reasons could be the most important for them to get vaccinated. Is it that they want to meet safely with their family and friends again? Is it to protect themselves from disease? Is it to keep themselves safe at their jobs? And you can also share resources like those on the CDC website or the COVID-19 Community Core. And finally, regardless of whether or not you have gotten your COVID shot, I really encourage you to keep an eye out for potentially suspicious information. If you see information on social media or online that may be questionable, I want you to think through certain questions before proceeding further. So if you see something and you're not sure if it's true, pause for a second, read the full article or page. Think about, are there sources cited? Can you trace back to the original sources? Does the web page seem well edited and professional? And do the other articles on the website seem factual? Also, what other sources are talking about this out there? Are there vetted news outlets that are reporting on this, like the Associated Press? Can you check Snopes or other fact-checking websites to see if they have flagged this information? Or can you log onto the CDC website or the World Health Organization website, or we can do this.hhs.gov to see if they have verified this information? And finally, is this information igniting a lot of emotions in you? Are you feeling outrage? Are you feeling fear? Is the language that's being used sensationalized? Is it drastic? Is it stigmatizing to people? Is the author of the content saying things like they have been silenced in other outlets, or that other sources are too afraid to post this information? These types of questions do not necessarily mean that what you are saying is automatically misinformation, but it does mean that you should really look towards trusted sources like the CDC or your medical provider to really verify some of this information before you share it further or believe it. And remember that even if you see something that aligns well with your beliefs, it's important to still pause and verify what you are seeing is correct. Thank you very much.
Thank you, Divya. So comprehensive. Don't go away yet. she's like, I'm done. That was absolutely phenomenal. One, just from the data you provided, the work that you're doing, but also the tips for people. And honestly, like, you really open up the heart of this entire initiative that we have at the center. And it is to make people of faith, clergy leaders within their congregations, trusted messengers within their community. And so looking forward to that next phase that this series is the foundation for. And that is engaging and developing and equipping voices of faith to be trusted messengers. And so thank you for that. I did have one question that I received via email, and I wanted to ask, and you touched on it a little bit at the beginning when you were talking about how initially during the pandemic, there wasn't the studies, the pregnant women weren't included in the first studies, like those were later. And so the question that I received was sort of that time gap. You know, that's also something that I'm constantly getting questions about and having to explain to people is sort of the patience with the process of medical research and discovery and how do you assess what the study is saying. And so you talked about that. And so wanted you to go into sort of how do you all combat, like that time gap seems to be like a very vulnerable point where misinformation can really just thrive. Because there's no answers, but people don't understand the process of your research. And then not just having the research and the study done, but as a policy analyst with your work analyzing the study. Can you talk us sort of how do you all mitigate misinformation during that time period?
Yeah, this is a really challenging problem. And, you know, there's not necessarily easy answers out there, but like you said, that there is this time gap because for ethical reasons, and of course, to make sure that the vaccine is safe in non-pregnant people first, pregnant women are not included in initial trials, but that evidence is gathered afterwards among pregnant women who do get the vaccine once it's authorized and used widely in the population. And so in this critical time point, I think it's important for people to really advocate that these types of time gaps and this lack of evidence is normal, it's expected. It's part of the process to make sure that these vaccines are safe and that we know as much as we can before we, potentially roll this out in a population. And it's also important to say that, if you see in this time gap, if you see information online that's saying the vaccine causes this, or the vaccine causes infertility, or that the vaccine causes birth defects, that evidence, there's an absence of evidence. So the people that are saying that don't have the evidence necessarily to really support that on a wide scale either. And so it does work both ways. And, clinical vaccines, there are vaccines out there that are really recommended and used for pregnant women. There's a whole infrastructure set up to make sure that, we are assessing these questions responsibly and as safely as possible for these women, because that's an important priority for us as well. And so that's what I would say.
Thank you. Thank you for that answer. And thank you for your contribution to today's conversation. And so next up, I am bringing to the spotlight Dr. Amber Weiseth. And so very critical, building upon what Stacy and Divya has sort of laid, really is very special, the work that you're doing. And so that sort of my sort of personal introduction to Amber before she speaks, it's that there's a certain, as we talked and met and she shared her work with me, the continuous thread that I heard from her work and her team's work. She's the director of an initiative called Delivery Decisions. Did I say that right? Mm-hmm. Very good. I'm always getting stuff wrong. Delivery Decisions Initiative. And it was just this constant idea of the questioning of themselves. Yes, we have this data, but now not just what do we do with it or ignore it, but what we're doing is not enough. I love that. And so the idea, again, what Divya was saying, how the study and the analysis of data. Here's Dr. Amber to share her work. Thank you.
Thanks, Dora. And before I start, I just wanted to thank Stacy for going first and for sharing such a powerful story. You're incredibly brave, authentic, and I know your aunt would have been really proud of how you shared her story today. So just wanted to say thank you. And Divya, I really appreciate how you addressed misinformation and wanted to amplify your message around vaccination for pregnant people. I work with hospitals all around the country, and I've heard too many stories within the past really even few months of pregnant women dying due to COVID and they were not vaccinated. So I do encourage anyone who's listening who still has questions and is not vaccinated to follow the steps that Divya laid out, reach out, have questions, be curious. So now I'll dig into my content for today, which I should start by introducing myself just a little bit more. So Dora said, my name's Amber Weiseth. I do have my doctorate, but I also have the privilege of being a nurse. And so I've been a nurse about 18 years, and I spent 14 years working at a community hospital just north of the Seattle area, taking care of thousands of families. And those stories give me a lot of impetus and drive towards the mission that I'm currently working on. So my current role is that I'm the director of the Delivery Decisions Initiative, which is a program at Ariadne Labs. And I'm also a research scientist at Harvard's T.H. Chan School of Public Health. So to start us off, I do want to acknowledge that the failure to provide quality and dignified care to everyone everywhere across the globe is one of the biggest causes of suffering and death. Around the world every day, there's these failures in the healthcare system occur because of these gaps of how care should be done or what we should do versus what actually happens in practice. Now, there's reasons for that, which I'll get into from some of our research, but wanted to at least start talking a little bit more about the organization I work with. So it was founded in 2012, but Ariadne Labs is a joint center. So it's a combined organization between Brigham and Women's and the School of Public Health at Harvard. And Ariadne Labs works on designing and testing, implementing system level solutions to close these gaps in healthcare. So to make the right thing also the easy thing. So our work began with the creation of the surgical safety checklist. This was created by Dr. Atul Gawande, Dr. Bill Berry, many others, but also in collaboration with the World Health Organization. And what this checklist is basically 19 items that different providers who are in an operating room would go through before starting the surgery to ensure that everything had been done and everything was safe to get started. So the original pilot of this 19 list checklist was done in 8 surgical centers around the globe, from places like Tanzania and also at University of Washington in the Seattle area. And their research showed that by using the checklist, they were able to reduce mortality and morbidity by about 40%. So pretty significant. Now, this checklist has been implemented across the United States and across the globe. If you've had surgery in the US, you most definitely had the checklist as a part of your care. And it's really reduced some of those gaps in care, some of those failures of intending to do the right thing, but having a failure or a systems error that prevents that from happening. So when we look at childbirth, the most common surgical error is actually a cesarean delivery. So this happens for a couple reasons. Either healthcare teams do too little too late. So where people maybe really need a cesarean birth, this happens much more in a global context, or in a lower middle income country and they don't have access to surgical procedures. Where in the United States, it's a little bit of the too much too soon, where we're doing cesarean deliveries more often than we probably need to. Now, cesareans are designed to rescue mom and baby. So if somebody's in danger, that's why we have it, is to, protect their life. But in the US alone, annually, there's about 1.3 million C-sections that are done. Now, this is huge, because in 1970s, the rate of C-section was around 6 to 7%. In 2019, the United States rate for cesarean birth was 32%. So in really one generation, we've had a 500% increase in cesarean births. And when you look at this by the hospital level, so let's say you're in a large city and you look at hospital A compared to hospital B, we see dramatic variation. So in the United States, we see hospitals as low as 7% and as high as 70%. What's equally important to point out, which is a lot of our motivation for what we're working on, is that, so in one generation, we've increased the utilization of C-sections by 500%. And in the same time, that mothers giving birth today are actually 50% more likely to die in childbirth than they were from their own mothers. And this is 3 to 4 times more likely if they're Black. Now, for every death that occurs, there's thousands more that experience complications, trauma, and suffering in pregnancy and childbirth. So these are really notable statistics that there's a lot of people that are working hard to be able to change, both in reducing C-sections and also in reducing maternal mortality, especially with the racial inequities. So with these statistics in mind, the program of the Delivery Decisions Initiative was started. It was founded by Dr. Neil Shah, who is a Harvard professor and an obstetrician. And he really spent those original years focusing on how to explore those gaps in childbirth, and especially those delivery decisions. Because what we discovered through our research that there's systems pressures, there's an overly complex healthcare environment, and teamwork can be a huge challenge. And so these led to a solution, which I'll tell you about in just a second here. But we first, like I said, we started visiting labor and delivery units across the country. And we heard from nurse managers, from clinicians, overwhelmingly about this pressure phenomena. We called it the pressure tank, because you would see that as a unit got busier or more patients came into labor, and maybe they were more critical patients, it became more and more difficult for the unit to function and to manage them well. So the idea of giving the patient the best recommendation or the best care became harder to do the more that pressure built up. Now, so we further explored this busyness and looked at data, and we're not doing visuals today, so I'll just kind of tell you about it, but we showed that there was an increase in likelihood for a cesarean delivery, an episiotomy, having your water broken artificially, and the use of vacuums or forceps for the delivery. Your risk of those things increased the busier the unit was, until there got to a point where it was so busy, then we saw a decrease again. But it demonstrates that there are systems pressures that impact clinicians' ability to make the best decisions or recommendations. We also did work on the design of labor and delivery units, and to understand how the design, the shape they were in, how many rooms, where they were at, could impact the clinician's ability to do highest quality work. So with this foundation in place, we began to figure out a solution. How do we help teams work better? How do we elevate the role of the patient? How do we create more accountability for the right recommendations for people? So in 2017, we worked with experts all around the country and ended up coming up with a design of a solution that we call Team Birth. There's lots more about it online, so definitely check it out. But I know I have only like 4 minutes left, so I'm going to have to do the fast version. Team Birth is a communication and teamwork process. It really centers around the woman in labor and their family. And it's really meant to elevate their role and to create communication that's transparent and shared across the team. So how this is done is there's a large planning board that goes on the wall. Many of you, maybe if you've been in hospitals before, have seen a whiteboard on the wall. So we made it really big so that the patient could actually see it and use it themselves. And we have the team come together and talk and go over 4 things every time when they need to make decisions or there's maybe a change in the course. The first thing is the team gets named. So the person that's in labor, the woman in labor, her name goes up there first, and any family members that are with her, because they're core members of the team. And then any other nursing staff, physicians, midwives, etc. The next thing that goes on the board is preferences. And this is really important, that we ask questions and that we're good listeners and that we hear what's important to patients, because it's not always the same. And we can do a lot of harm by making those assumptions. The third thing that goes up is the plan. And we write out the plan for the mom, for the baby, and for labor progress. And those are all written in transparent, patient-friendly, understandable language. And then the last thing, which some of our patients report this as their favorite thing, is the next assessment. So we write on the board an agreed time that the team is going to come back together and have this transparent conversation again. And, a lot of women in labor have no idea what's going to happen next. I mean, either doctors don't know or nurses don't know either. There's a pathway. We know that what generally happens, but we can't exactly predict it. So for a patient to know when the team is going to come back together, we're going to have this conversation and they're going to have an opportunity to have their voice heard, is really a really powerful statement. So we've tested team birth across the country. We did a pilot trial in hospitals on both coasts, so Massachusetts and Washington, and also in the heartland in Oklahoma. And overwhelmingly, our data showed that 90% of our clinicians would recommend team birth. They felt that made care better. And of our patients, we had 79% of our patients feel that sharing their preferences made a difference in their care. 87 said that they had the role they wanted, like the voice that they wanted in their care. And 94% felt that clinicians communicated with them in a way they could understand. So we are currently testing team birth in hospitals in Oklahoma and Massachusetts to understand the impact it might make on racial inequities in childbirth, and especially of giving voice to those who have been most marginalized historically, because all people giving birth really do deserve the right to have a safe and dignified birth. And team birth is an evidence-based solution that elevates the role of the patient and supports the principle of beneficence for doctors, midwives, and nurses by making the right thing the easy thing to do. So, Dora, I don't know if we have time for any other questions, but I went right to the mark, so I apologize, but thank you so much for having the opportunity to share our work.
No, you were absolutely wonderful. Like the follow-up questions, I had two, you answered, so that's great.
Oh, well, there you go.
Because you tied it right back into the principle that we're talking about today. So thank you for drawing that so very well. Thank you for your work. And so I'm going to pull in if Divya and Stacy can come back. I have a closing thought, but I wanted all of your thoughts on it, if you will. And it was something that Stacy had said in her opening. And it was the phrase she said, well, it was two things. And when she said her aunt should have been protected, and it's that should have, that really touched me, that hit me, because it is that responsibility that we're talking about. That it's not random acts of kindness when we're talking about beneficence in healthcare. And so I applaud your work, Dr. Amber, because you all take the responsibility very, very seriously. And so I'm so thankful to be able to amplify your work as an example, as a model of what we're talking about. But when Stacy said that, she didn't follow it. She talked about the love, how her aunt went feeling that she was not loved because she could not bear children. And I want to connect those two, the two thoughts, because again, the reason why I immediately felt that ethics was a space for us to focus on as a center in our faith-based work, it is because beneficence is a principle in Islam. It is the nature of God himself. It is one of the two most oft-repeated names of God. He's called the Beneficent, the Merciful. And so I immediately was drawn further into ethics and studying it when I learned that, not for us here at the center. And it is that concept of God is love. And so what we're talking about, even though Stacy had the framework of sort of the personal romantic, she felt not loved. What we're talking about is medicine, the health security that Divya talked about, at the foundation of that, it is the principle of love. It is the principle of humanity and understanding the humanity in others. So I just wanted your feedback as I'm sharing that thought before I close out with the final quote. But it all drew it all very wonderfully together when we say God is love, that is the truly the principle of beneficence in healthcare. So feel free to give your closing thoughts. But that was my sort of, yes, to pull it together.
Dora, that was really beautiful. I love how you brought that all together. You kind of made us all teary again. So thank you for that. I did want to address Kim's question around the teen birth approach been shown to reduce C-sections. It's a great question. So in all of our pilot hospitals, C-sections were reduced. However, back to Divya's talking about the limitations of research, we were not doing an effectiveness trial at the time. We were really looking at, do patients like this? Do they want to be a vocal member of the team? And will clinicians do this? Will clinicians like it and do it? So it was really an acceptability feasibility trial. So our research was set up to demonstrate that. We can't claim that we caused cesarean birth rates to go down. However, I can tell you that in all 4 of the sites, they did decrease and have stayed low. So we're looking to do a more rigorous effectiveness trial so that we can use more fancy scientific terms to say that we caused that.
Again, the principle of what we've done is not enough.
Yes.
Thank you for that. Thank you, Kim, for that question. Thank you, Amber, for checking the chat for the question. Divya, your closing thoughts?
I just want to thank you so much, Dora, for inviting me. And I want to thank Dr. Weiseth and Stacy for sharing your wonderful work, as well as the really powerful story, Stacy. It's really a pleasure and a privilege to have this opportunity to talk with everyone. And I do really think that Dora, what you were saying earlier about beneficence and the ultimate goal of doing what's best for people and working to protect people especially during this time during a pandemic. I mean, that's, I think, the ultimate goal of a lot of the work that we are all doing, and we're all doing it in our own unique ways. I just think that we should have more opportunities like this for people from doing different work from different fields to come together and to really talk about how all of the stuff that we do intersects with the ultimate goal of protecting people. I think that, as we move through this really challenging time of a pandemic where, it sometimes seems like there's no end in sight, and it's really hard to kind of it's really kind of hard to see an end line. I just want to encourage everyone to reach out to people they trust to get the information that they need, and to not feel shy about reaching out to your care team to learn more and to get the answers that you may need to make the decisions that are important to you.
Thank you. And Stacy, began with you, your closing thought.
Thank you. I just feel so honored to be on this team with such accomplished and intelligent women, and that, who knew that my aunt's story was going to take me to this place, and that I know that that would not happen today. And I'm so grateful that, everyone's was willing to hear this message, because it is not an easy one to hear. And so I just am grateful to be on this team with all of you. And thank you all for listening.
Thank you all for joining me. And my closing quote, before I send everyone to enjoy the rest of their day, is a quote from Immanuel Kant. And he says, "Beneficence is a duty, and he who frequently practices it and sees his benevolent intentions realized comes at length really to love him to whom he has done good." And that is the basis for what we've talked about today. So thank you all for joining me. Thank you, 3 women, for sharing your experiences, your wisdom, and your heart. And to everyone who's listening and watching this after today, definitely, please complete the survey. Definitely want your feedback. You all have a wonderful day.